Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to introduce Mike Smilanich. Is that right? Mike, did I get your last name?
You put an extra syllable in there, Phil, but it's Smilanich.
Smilanich, okay.
They're very close, though.
Yeah, and you are a dentist practicing, or were practicing up in Minneapolis, Minnesota. You're a GP, a class of 1983, and you are now the VP of Clinical Affairs for Kovanaze, or St. Renatus Company. Why don't you give a little bit of introduction to yourself, and then we'll go into the product next. But for people that don't know, that's the nasal anesthetic for dentistry. So Mike, thanks for being on the show today. And why don't you kind of give the listeners some history about yourself?
Thank you, Phil. It's an honor to be able to visit with you guys. They didn't have podcasts. Started doing implant dentistry. As Phil said, I'm a 1983 grad out of the University of Minnesota, and I'm a restorative doctor. We weren't allowed to do implants in the early 80s. It was a very different landscape. And there was two, if you can imagine, there's two different implant companies. So that's been my history in practice, private practice to this day, more limited now. As Phil alluded to, I've gotten real busy with the St. Renatus Company. But my first full mouth implant case was in 1984. 5 implants on the bottom, 4 on the top, fixed hybrid, as we used to call them, on the bottom, and a clipped retained upper denture, which was still in place until 2 years ago when the gentleman passed away. So for those of you who haven't been practicing as long, when done well, your implants will be there when you're retiring. So that's kind of neat to know. Kovanaze is the second most exciting thing that happened in my practice in the 34 years. And if I was looking at a timeline of dentistry, the biggest arrow would have always been implants, because it was a revolutionary change. You know, in the past, you took out a tooth and you had to replace it with a bridge or a partial or some other non-stable entity. And then came implants, and lo and behold, in it goes osseointegration, and voila. Well, anesthesia has been the same since we quit restraining people, in that it's always been injectable. And to be honest with you, the things I'm going to talk to you about, I want you to understand, I know you're suspended disbelief, because frankly, if it doesn't come out of a needle, it doesn't work. And that's been my 34 years of experience. So I got involved with 2 characters from my class, the class of 1983, and they stumbled on this chemical combination because one of the doctors broke his nose in a basketball game, and he went to the clinic and he was sprayed with a product, and he went back to his dental office and he was testing the palate, and he does a lot of endo. He had an endo reamer or a file, I'm not sure which, with a stopper on it, and he was playing around with the incisive papilla and the incisive canal, seeing if he was numb, and he unfortunately sunk the instrument into the stopper before he realized and removed it. And that was the aha moment of discovering, the analogy to osseointegration, realizing the camera didn't come out of the rabbit leg. Well, this was, my palate's completely numb and I got something sprayed. So I began working with them a number of years ago. I've been around the drug for probably 15 years, and it got FDA approval in late last summer. We can talk a little bit more about that. But Kovanaze is a combination of 2 old drugs that predate the FDA. Tetracaine, Stanley Malamed calls it the Rodney Dangerfield of anesthetics. It doesn't get the respect it should. And Oxymetazoline, which is essentially and completely Afrin nasal spray. So those 2 combined and put in an atomized dose, a 0.2 mil dose, achieves this profound anesthesia that we're going to talk about. So even though Tetracaine has been around since 1941, and Oxymetazoline predates the FDA, it's kind of like making a Reese's peanut butter cup where you mix peanut butter and chocolate. And when you mix the peanut butter and chocolate, you have to start all over. So you have to go through roughly $80 million in studies and 10 years of FDA submission, and then you submit a new drug application. And if you're as fortunate as we are, you are granted one after those 87,000 pages of tables and statistics. So when a drug comes through dentistry nowadays, it is vetted, and even when they're tool drugs like this. So Phil, I'm going to stop, or I'll start preaching from the pulpit here, and let me know what you're interested in.
Yeah, well, I think this being a relatively new product, I think people are excited about it. Maybe a lot of people haven't heard about it. So the idea here is we're delivering anesthetic for the upper teeth without having to inject patients. I mean, why don't we just go in with obviously some of the entry-level questions. First, just kind of, how is it delivered, and what are the uses for?
What happens, Phil, is it's in an atomized device, the same one that's been used for other nasal sprays, the flu vaccines and whatever. And it's a 0.2 milliliter dose, and it's a single, completely empty the sprayer application. So you push firmly and spray, and you launch in an atomized spray 0.2 mils. And in that 0.2 mils is 3% Tetracaine, and that's 6 milligrams. It's just a tiny, tiny dose of Tetracaine. And there's 0.05% Oxymetazoline, which is a very, very low dose of Afrin nasal spray. And that's a 0.1 milligram. And so, for example, if you go to the ENT, ear, nose, and throat doctor, and they do a polyp, they're going to use an unmetered dose of 4% spray from a pressure pump. So if you go to have a polyp removed from your nose, the ENT goes, and it's about 70 milligrams of 4% Tetracaine, to give you an idea of the microdose we're using. And the reason that dose is so small is because it's that effective. So we'll talk a little bit more about that. But the interesting thing with this, again, is everything for us, every advance in anesthesia, the last one really being Septicaine or Articaine, which for those of you who were around only since 2000, that was a huge revolution or evolution for injectables, in that you could numb individual teeth in the mandible. And it took a little while to catch on, even though it was in Europe and Canada. But this is really revolutionary, and that's what's so hard to get your head around. And that's what I try to explain to doctors in programs is, and we do a lot of programs on these if any of you are interested. But there's 4 big components of Kovanaze. It's needle-free, which essentially to me meant baloney, it doesn't work. And we've disproved that. It's extra-oral, which is crazy. You spray this in the nose, so patient doesn't open their mouth, and you're able to numb the majority of the maxilla before they say, It's regional. We don't have a lot of regional maxillary blocks because of the proximity to the foramen and the upper jaw. In the lower, it's easy to numb the inferior alveolar. In the upper jaw, you're getting close to big bundles of nerves and vessels. And so a lot of us don't use anesthesia in the maxilla unless it's supraperiosteal or our infiltration. The problem is if you're doing veneers from 4 to 13, you come to my office, I'm going to use 20% benzocaine. Then I'm going to probably use prilocaine or Citinest so you don't feel a sting. Then I'm going to go back and I'm going to use lidocaine or articaine. I've given you probably 12 to 14 injections, and you can do the same thing with 2 sprays, which is remarkable. So needle-free, extra-oral, regional, and then FDA approved. It comes to the acronym NERF, if you can't remember the stuff. And the FDA approval is remarkable because of the things we have to go through to achieve that. The indications, which are somewhat limited compared to what the drug is capable of, but these are, again, have to be tested and vetted, and the expense in doing these things is formidable. The indications are for restorative procedures, fillings, crowns, anything deep involving necessary pulpal anesthesia, restorative procedures for teeth 4 through 13 on adults and A to J in adults and children. And so we tested down to 3-year-olds. For those who are interested in pedo, again, this is more of an implant presentation, so we know we're not going to be using implants in undeveloped kids. And the dosages aren't related to weight, as you'll see in the package insert, which is because they're so low. 3-year-olds can have 2 sprays. 7-year-olds can have 2 sprays. Adults can have 2 sprays. Now, there is one caveat where if you have an adult that you want spray or use more anesthesia, 18 years or older, adults, unrelated to weight. If you're over 18 or older, you can have a third spray. Again, that's a max dose of 18 milligrams of 3%. If you break your nose, you're going to get 70 to 80 milligrams of 4% at the medical doctor. So by comparison, and that's why these doses don't have weights attached to them. So if you're looking at a smile, and this is really an incredible thing about the drug, if you're going to numb, if you spray it in the right nostril, and obviously we have a right nostril and a left nostril we can administer. If it's sprayed in your right nostril, teeth number 4 through number 8 are going to get profoundly numb. Spray it in the left nostril, tooth number 9 through number 13 are going to get profoundly numb. Now, again, the indications are for the pulps and the nerves of these teeth. We'll talk more about other things. The remarkable thing is its effect and how it acts on the patient. What happens, if we had graphics to show you, is if you look into the nose or the nasal cavity, and most of us haven't since we worked on cadavers, right? I don't operate in the nose. I don't look at the nose. It's there. If you go in and see a scoped nose, nasal cavity at the ENT, you'll see the turbinates are the big structures in there. And your inferior turbinate's as big as your index finger, and your middle turbinate's the size of your pinky. And those are very vascular, and the drug is deposited with a nasal spray on those turbinates. Tetracaine is very invasive, and it works through tissue. It's an ester, and it's very lipophilic. It goes in and finds the nerve, and it attaches to 2 branches of the maxillary nerve, the MSA and the ASA. And if you really want to know what the drug does, Google the ASA and the MSA and the things they innervate, because everything that those 2 things innervate gets profoundly numb. That's not all in the indications, but if you look that up, it'll tell you exactly what happens. And it's happening through the nose. What it doesn't do, and you'll follow this through the nerve branches of the ASA and the MSA, is it doesn't provide any anesthesia to the lips. So your smile display, if you're seating veneers or crowns or any of these things, you'll get profoundly numb teeth and everything else, but your lip is fully formed. You have no chimp lip or dead philtrum. So it's remarkable for aesthetic cases as well.
That's got to be one of the highlights that I can think of. I know this is an implant podcast, but I do plenty of veneer cases, and I just seated a upper 10 veneer case this morning, and I thought, man, I wish I could have had some of that, because you try on your veneers and crowns, you want patients to smile, and their lips are numb, and then you want to get approval to seat the case, and they can't see their lips, so it's kind of
You're exactly right, Phil. My biggest frustration with aesthetic cases, it would be Stanley Malamed he and I did a video. It's on Stanley's is on the ADA website. If you go to that, he talks for about an hour on the drug. And one of the things Stanley talks about is that the things it doesn't do are as important as the things it does do. And that's a good source for more information. Because again, how many veneer cases you have problems with, because the lip display is so different than what you saw with the chimp lip and the dead philtrum. Now, coachable moment. Say you're doing a crown on number 18 and you're doing a crown on 15 and you block 18. When you start the procedure on 15, patients will sometimes say, doc, I'm not feeling that, but I'm not as numb as on the bottom. Well, you guys, we all know why as doctors. Well, now you're going to have to learn why. You're going to be able to prep 10 veneers in the upper right to the nerve of the tooth, but their lip's not going to be numb. So they're going to think they're not numb, right? Because anesthesia has always equal paralysis. So each and every one of you that is going to become familiar with this, if you choose to, you must experience it yourself, because the feeling is so different. When you're sprayed, Phil, I can describe what happens when I'm sprayed.
Yeah. Go ahead and tell me, because you've had the drug yourself, right? I mean, you've had this done yourself. Yes. What are the effects that you felt?
Well, one of the things we do as well is when we do study clubs, we allow doctors to dose their partners and doctor to doctor to experience this sensation, because it is so different. So the first time that I was sprayed, right nostril, there's no sensation, there's no sniffing, and the administration it's passive. So it's just sprayed in the nose. And at about 2 minutes, it begins to act, 2 to 3 minutes. And the first thing that I sensed was the distal of number 4 in a line directly across to the lingual of number 10, sort of the contralateral lateral. The palate gets profoundly numb, nearly in 2 minutes. 3 or 4 minutes, there's no other sensation. The palate's getting number. And when you tap your teeth or touch your teeth, it's impossible to not notice, even with lip pressure, that proprioception is gone. So the ligaments of the teeth, and again, you've never had that sensation. It's odd. If you can always tell a dental professional or hygienist or assistant who's been sprayed because they're tapping their teeth, and they'll tell you their teeth feel like wood. Now, they'll tell you that every time, wood or stone. And if you endo ice test them at that point, you'd get a negative nerve response to minus 27 degrees centigrade. So they are numb. But if your assistant, if you're ready to go and your assistant puts a cotton roll in there and pinches their lip, they're going to jump because it hurts. Their lip's awake. And that's just a coachable. Don't forget that. If you're going to administer on the opposite side, the exact mirror image would happen, and you would cross the palate again to number 7, from number 13 to number 7. So if you drew a map, that's what your sensation is. And again, this profound loss of proprioception. Now, we also find that about 50 to 65% of the time, the molars get numb too. But 50 to 65% stinks in terms of efficacy. This is a drug that has to provide efficacy. There's no such thing as being kind of okay and comfortable. You got to be numb. So our efficacy reports are 96% across the board on teeth 5 through 12. You get them numb every time. If you Google our other options, like in infraorbital or any of our other injectables, none are close to 96% across these teeth. None. And it's remarkable. Arguable point, doctors have said, if it came out of a syringe, I'd buy it and accept it right now, because I would understand why that would work. It's disbelief because it's not inject, and that's why doctors have to experience this. So you notice I skipped 4 and 13. 4 and 13 anatomically, some people are missing the MSA branch. And Stanley and Malamed and I talked at length about this. When that MSA is missing, some people, a small percentage, 20% or so, will have some anastomosis from the PSA nerve. And so some people on 4 and 13 will still have some sensitivity with real deep pulpal procedures, a root canal or whatever. You're probably okay even in those individuals with veneers or crown prep. So really exceptional efficacy. In the pedo studies, it was even better, but the FDA placed a 40 kilogram weight limit on children. And I have to explain that for a second because I didn't understand it, because I was there for the pedo studies and they were remarkable. No anesthetic, no injectable, and no nitrous, and these kids were just little angels with deep procedures. Well, what happened is some of the kids were okay, even on these deep procedures, with our placebo, which was everything except Tetracaine. So it was benzyl alcohol and Oxymetazoline, et cetera. And that's called pushing the placebo effect. So if you can't explain with double blind that it's that chemical that's making it that much better, it doesn't matter how successful your trial was in terms of clinical efficacy. So I just want to make sure no one thinks there was an efficacy or a safety issue. And the pedodontists who tested the drug are using it on all their patients now, despite the fact that that's technically off-label. So Dr. Greg Evans in Fort Collins was our principal investigator for pedo. And on his website, he goes into great detail about how much that's changed his practice. So it's got a lot of applications other than implant dentistry. Now, if you practice implant dentistry and you follow what I described, the branches of these nerves innervating, you can see how exciting this would be for some of our procedures that are in the anterior maxilla. So essentially, from molar to molar, it is a great adjunct for all of our surgical and restorative procedures with implants as well. Some periodontists and implant surgeons who are obviously not working on any live nerve pulpal anesthesia areas are using it as a pre-anesthetic if they're going to follow up with injectables as well. Because of this, you can imagine, or maybe can't, about how your patients would respond to not have to have all those shots for veneers or for implants.
Yeah, it really sounds like kind of a game changer, because the zones you're talking about, one, are some of the most uncomfortable shots you can give. If you're talking about, the palatal areas of the tissue and or each individual shots, the amount of shots you have to give sometimes if you're doing, veneers or if you're doing implants of an area, and the amount of anesthetic you have to deliver, you're getting at maximum doses. This allows you to really minimize the amount of dose you're using, the number of injections, patient discomfort. I mean, all the negatives that come with traditional local anesthetic, you're being able to minimize all the negatives with, 2 squirts up the nose, basically.
It's remarkable, Phil. And again, practicing for 34 years, I'm sure you guys give good injections. We do. But patients, okay, there's 2 words. Patients call it shots. We call it administering anesthesia. We call it prepping a tooth. They call it drilling the tooth. And the reason is these patients, it's a giant. Stanley talks about it every time he does a course, Stanley Melamed. The biggest emergency in a dental office is syncope, fainting, issues from the administration of anesthesia, unrelated to the drug. It's related specifically to the shot and the puncture in the mouth of an injection. And we as a company are not allowed to talk about this. I just probably went in a direction I shouldn't, but anyone who's practiced for more than a week knows exactly what Phil said. No one likes injections there. No one likes to give them there. If I could take your blood pressure, Phil, where you're injecting somebody for veneers, it's higher.
I mean, that's what my patients always say. It's not not really the drilling that bothers them. It's those shots. And I try to do a good job, and I care, but it's just the reality of the beast there with that. It's the pain with that, and if I'm doing a bunch of procedures, my concern is dosage. How much can I safely give, and is all that epinephrine necessary? And there's just other issues that you worry about as a provider.
And they're all real. And as Stanley talks about, it's the devil we know. I mean, and think about this. And I really get angry when doctors or when people say, we want to get rid of these bad shots. No, shots are what separate us from monsters, guys. Without injectable anesthesia, we are literally restraining patients. So it's the best thing that's ever happened to us on one hand. On the other hand, no one wanted an electric car 2 years ago or 3 years ago till they made a Tesla, right? And so this behavioral changing, if you graph behavioral changing consumables, the 3 that come to the top of my head are the Tesla, the smartphone, and dental implants. They all take a little while for people to go, seriously? A screw in my jaw? An electric car? A phone that I don't need a laptop? Yes. And they all graph about the same. They have a slow acceptance curve for about the first X amount of time. Then you get that exponential, holy smokes, this is the greatest thing since sliced bread. And I'm there, and I've been there for a while because I've gotten to see this and use it, and I see what patient response is. The obvious thing for the company is to release this to the consumer. And I've been pretty much the only one that's prevented that, because as doctors, we can't stand when patients come to us with something that we don't know about and ask us about this new thing, right? I don't want shots anymore. And I understand you don't have to do that. That's the backwards way. I want to get all the doctors, I'm going to get this in your hands. I want to get you guys understanding it and being able to talk, whether you like it or not, with your patients. And then eventually consumers will follow and pull. But the doctors who are using this in their practices are overwhelmed by, oh my goodness, I didn't know patients disliked injections that much. They're getting, the rest of the family comes in, or the guy down the street who just had a root canal and they had a shot in the roof of their mouth. They heard you don't have to do that. So it's been really remarkable.
Yeah, I think I'm already excited for this, and I can't wait to get some in my office. The first batch I'm going to use it on the first upper anything that I do, and I'm going to film it. I'm going to get my iPhone. I'm going to have my assistant film it.
Yeah.
I'm going to have it, and then I'm going to do the procedure, and then I'm going to film the patient telling me how it went, and I'm going to put it on my website, and I'm going to put it on my Dental Implant Practices Facebook page, and just see what people think, because I guarantee you, if people go to my website and they see that and they think, oh my gosh, they didn't get a shot, and they said, what a deal. I mean, that right there is going to get you 100 patients.
Phil, you can talk about how much you care about patients. This is a way to show them, and they get that. This is a visceral response by patients. There's cerebral selling and visceral selling. When they can feel it cerebrally, this doctor cared enough to find this new product, use this new product. He cares about not giving me shots. It's really remarkable.
Yeah, I mean, I can already think of because anymore people, people shop around for their dentistry, and they shop around for their clinicians, and this is one of those things that can seal the deal for you and say, look, maybe for half of the amount of the work that I get done, I don't have to get shots for.
Phil, one of the things as an agent of the company, as a person being around it, I lose a little bit of this because I've been around it. Sean Boynes, who's an anesthesia guy, and he did a podcast for us. And one of the things he said was, and again, I did my first case in '84, so you can guess, my technology expertise on some of these things. But he was explaining how patients leave your office and they can give you a Yelp review, right, in 2 minutes. Now, it doesn't matter what happened. It's what the patient says. And if you have something, he's like, use this fact, which is people are going to Yelp and make reviews. What about when a patient leaves and said, I didn't have a shot? And, there's only one first prong. So like with implants, I was one of the first doctors in my area doing implants. And it was adopting new technology. It wasn't accepted at the time. And it could have backfired and blown up on me. But it built a practice that I continue to enjoy to this day by putting this new technology in. And this is a technology, not just a drug. It's an administrative fashion and a drug. And this kind of thing coupled with lasers or uncovering procedures. I mean, you can, off the top of your head, come up with some of these things. There's a sidelight, a couple quick clinical things. You're going to get about 60 to 90 minutes of duration with it. It depends on your patient. And what you'll find is if you use it in conjunction with an injectable, doctors in the field and clinicians describe a very clear synergy where if you spray a patient and you, in some areas sensitive and you need to administer an injectable, you can administer whatever you'd like. There's not any interactions. You can't use more of your injectable than you would, alone. You still have to obey the rules of administration, but you're going to get a 1 + 1 = 6. So where you typically use a carpule of lidocaine, you'd use a fifth of a carpule or a tenth of a carpule. And that's been very clear. A sidelight I was saving for the end is it's considered a topical by the FDA. So even your assistants can administer it. So Phil, if you're going to do a set of veneers, your assistant or hygienist or whoever you train carefully can go in and do the procedure. You walk in and place cotton rolls and begin the procedure. Heaven forbid, the worst case, number 13 has an MSA spot and you have to use a tenth of a carpule of lidocaine. The patient won't feel that injection. In fact, you wouldn't even have to tell them you used an injection. And that's the worst case, is you might add a drop out of 10 veneers. I'll take that worst case all day, right?
Yeah, absolutely. And the fact that, I didn't even realize my assistants could place it. I mean, I guess my mind was already drifting there. I was going to ask you that, but the fact that they can seat my patient, take any x-rays, take any impressions, place that, I can walk in and start drilling, and I can say, hi, how are you? Lay back and start drilling. I mean, right there, it's, how much I got to go in, deliver anesthesia, go drink coffee, check my email, make some phone calls, and then come back in 20 minutes and start drilling. I mean, I walk right in and get going. That right there for chair turnover is worth whatever cost whatever cost the, nasal spray injection is.
Well, and that's an interesting point. It's much more expensive than injectable. It's coming down monthly because of our production costs. Our intent, and we're very serious about this, is to get this down to about $10 a patient. Now, we're not there yet. But when a doctor tells me that it's too expensive to use because he can get local anesthetic at whatever, $1 a carpule or whatever, my question is, the guy who bought this down the street from you has a patient who's not going to get any shots. So you're not thinking about this correctly in terms of cost and value. So he's got a patient he's not administering anesthesia to. His assistant is administering it. He's seating crowns or doing something that doctors only can do in the room next door that he's getting paid for. So it's not only not costing you more than local anesthetic, it's making you a ton more money. It's just, if that's the way you think, you're going to be a user of the drug. If you think the other way, where you want to do an injection and stare at the patient until they get numb, then maybe an injectable is, for those doctors, that might be the best way. So like all things, it's another tool in our toolbox, but a remarkable one. And there is a buy one, get one promo that I believe goes on for at least the next month or so. And it's available through any of the distributors if anybody is interested. So they can also call the St. Renatus line Benco or Atlanta or Shine or Patterson or any of the distributors have the drug available as well.
Well, let's talk about that a moment. I know we've kind of gone through some of the indications for use, some of the applications that you can use this with, some of the onset time. So it takes 2 to 3 minutes for the palate, 3 to 4 minutes for the teeth. Duration might be 60 to 90 minutes. It's got a synergetic effect with the other injectables. All this sounds great. You're saying that the cost is a little more right now, but can come down. And if you really see the true business benefit in this, it's kind of a no-brainer. Where do I go about getting this stuff? I mean, I'm just, I heard about this stuff a month ago. I want to buy it basically as soon as we get off the phone. How do I purchase this? How do I get it in my office? How do I store it? And like you said, who can deliver this? You said anybody, my assistants and hygienists there. So just kind of go through that.
I'm going to do that and expand a little bit too as well, Phil.
Sure, absolutely.
There's a Kovanaze website, which I have grown children, and our Kovanaze website is not nearly what it should be in terms of flash, I'm told, but it has a lot of facts. And one of the things it has is a 7-minute training video. If you go under the doctor segment, and we filmed that. Unfortunately, you'll have to put up with my voice again, but there's a training video that I really encourage you to watch if you're going to use this product. It's very intuitive, but also, if I were to tell you all how to tie your shoes and you've never tied shoes before, everyone's going to tie their shoes and about 10% of you will get it exactly right. Now, we'd like to do better with anesthetics. So it generally takes a couple of tries, and I strongly urge all of you to feel it once yourself and on an assistant or a colleague as well, so you guys can kind of talk about it. The onset's a little different, Phil. What happens with an ester is it's lipophilic, it grabs onto the nerve very tightly and you get good duration, but it takes a little while. And also it's migrating through tissue from the turbinates. So the administrative directions are these: 1 spray, and in any state in the country, I believe there's 48, that assistants can apply topical. Your assistants can apply the drug, as well as your hygienist, of course, and the more highly trained clinical people. And so 1 spray is administered, 4 minutes waiting time, and then a second spray. Now, to be honest, there's a lot of doctors clinically that are finding great success with a single spray. And that's a sidelight, and that's not in the indication. The indication is for 2 sprays, 4 minutes apart. Then there's a 10-minute wait. So when you were talking, Phil, I was smiling about what you would do. You'd have your assistant administer, you'd go do this, you'd go do that. Exactly. And because you're going to be at about 14 minutes before I would pick up the drill and start a deep pulpal procedure or a root canal or whatever. NYU is currently doing an endo study. Paul Rosenberg, who wrote the book on endo pain, he and I are working together on this endo study on Kovanaze patients. But we didn't test that in the clinicals. We just test deep drilling procedures. So you're going to be at about 14 minutes. When you administer this yourself, many individuals will be profoundly numb at 4 minutes. And if you want to test it, the surest way is to have a little bit of endo ice available and put some on a cotton roll and touch number 6 or 11. And generally speaking, by the time you do the second spray, most of them will be numb. Our biggest concern to describe the reason, we don't really have solid scientific evidence as to why we would use the dosage was so small. 2 sprays is 12 milligrams. So we did triple max dose studies at Penn with Elliot Hirsch, where we sprayed 6 sprays per side, 12 sprays per patient with no ill effects. There were some blood pressure differences of less than 5 millimeters, but the studies are all available on JADA. So it's a micro dose of this. So 2 sprays were chosen because we wanted to make really sure that we were hitting our 96% efficacy. So with 12 milligrams, we get that. Again, a lot of doctors, as they will in the field, will go, well, you know what? I'll just try 1 spray. And we're doing some single spray studies now. We'll have more information for you soon. But the technique is spray 4 minutes, spray again, 10 minutes. You're about 14 minutes before you pick up a drill. And again, many doctors won't have seen the patient yet, other than for hi, how are you? So then you're going to find that there's no sensation to the lips and proprioception only. So patients don't perceive this as leaving with a fat lip. So when we say it's 90 minutes of duration, if you had a concert oboe player or someone playing taps for Memorial Day, they can leave and go to their job, which is remarkable. There are a couple things you'll see in administration techniques on the video. One is this is clear. It's something sprayed in the nose, and that's not our field, right? We're dentists, and all of our chairs tip back at a couple degree angles. You want your patient sitting completely upright. So I'm a right-hand operator. I have my patients swing their feet over the edge of the chair to face me, so we're knee to knee. That's how I administer, because then they're sitting up. If you spray them laying back and you don't spray it quickly enough, you'll get some in the throat, and it doesn't belong in the throat. It belongs in the nose. And doctors who spray with the patient laying back, if you forget, because all of our patients are laying back, you'll get some dysphagia. You'll get like a little topical in the throat. It's not harmful, but that's supposed to be in the nose working, not in the throat. So that's all very clear in the video. And you want to spray quickly enough so it atomizes. And doctor after doctor who doesn't pay attention to that will shoot more of a stream into the nose on themselves usually, or their assistant, and they're going to get the throat numb. So it's very simple, but those are just a couple of picadillos that you'll see. The drug works. So if any of you are using it and you have issues, call me. I will get back to you if I can't pick up immediately, because they're fun calls. The drug works. It's like a free throw. You just have to get the ball, in the rim. It's available from any of the distributors. And if you have any trouble, if you call your distributor, you go around them and contact St. Renatus directly. But any of the distributors, any of the major distributors that I can think of, the drug is available. And it should be currently, especially for the podcast people, a buy one, get one. And that won't stay, believe me. So you should make sure you check on that and make sure you get that from a dealer. And if there's issues, again, call our customer service number. Philip, I might have strayed a little bit from the boat there. Bring me back.
Okay. Yeah, you were talking about 2 sprays and then a 3rd spray max. Now that's per nostril, correct? I could deliver, if I'm doing implants on both sides or full arch stuff, I could do 4 sprays. So 2 on one nostril, 2 in the other, correct? Our
max dose studies, Phil, were 12 sprays with no issues. So we're seeing all different things from the field, but yes, many doctors. So another thing to clear up is the indications are for unilateral dosage and spraying. And that's kind of crazy, because every study that we ever did, and there were many, were bilateral. And the FDA was with us on this whole thing. The FDA loves this drug because we vetted 2 drugs that they'd been grandfathering in forever. No one even knew what oxymetazoline did. I mean, it was over the counter, and it was amazing the information that the FDA got from us. But they're all bilateral studies, because obviously it's an aesthetic zone, upper maxilla, premaxilla, 4 to 13, zone. And the last and final study that the FDA raved about was to prove that it works ipsilaterally. It works individually on one side. You don't have to spray, prove that you don't have to spray both sides. So we did. That's the study that got written up and accepted. So the indications list the unilateral spray, which is kind of backwards, but that's how it happened. So
you talked about the lips not numb, and then you talked about proprioception. So are bite adjustments easier after this? I mean, sometimes that's the problem with when you numb patients. Let's say you do crowns, or you're delivering a crown, and you're trying to get bites adjusted. Have you noticed any difference in being able to get bite articulations better with this drug?
You'll find that your lack of proprioception, good question, Phil, seems to be, and again, I don't know how we'd study this, but in my hands, it's made up for the fact that nothing else is numb. So it's hard to imagine until you sense it yourself. but you can tell when the teeth are together because most people could feel the molars and you can feel the lips. That's one of the things that makes it so difficult but we've never had the ability. How would we know what proprioception was like when lips weren't numb? Because it always goes together. So it's really like being in a different world when it comes down to patients they can feel the buckle. If a tooth is too bulky or an embrasure isn't right, or you don't like something, these are all things we would operate blindly on cosmetically in the past. Now the patient's wide awake. It's incredible. And though, again, it requires some coaching because all of us, to a person, have not ever had deep pulpal anesthesia and wide awake lips. So it's really, I can't overstate that enough, is you have to think about that because patients will give you false positives that I'm not numb. No, I understand you don't feel numb, and this is this and this is that. Couple of tips. I always hand my patient a tissue. Your nose will never run because it's oxymetazoline. So it's going to open your sinuses and actually open the passages. But if you're going to use it unilaterally, it's the same sensation as spraying Afrin in one nostril. That nostril is going to feel big. It's going to feel like you're getting more air in. And so if you spray a patient unilaterally, they're going to talk more about the different sensation than they would if you did both sides. And I hand the patient a tissue because it gives them permission for their nose to feel different. And it does. It feels a little different. The outside doesn't feel numb. It's the least sensation we've ever had with a deliverable anesthetic, that's for sure. But it's different.
Yeah. It's just, it sounds like the first person I'll be using this on is me when I get it because I like to know what's going on. And I like, I'm a scientist and a dentist and an entrepreneur and all those things in one. So obviously, unless it's root canals or implants, I like to try them on myself first. And I want to know what this is like, and then I can't wait to get it going in my office and just start seeing the effects that patients have and love it. And I know that it's got uses. Maybe every good drug has uses, in my opinion, outside of what the FDA clears it. I think Botox is the biggest example of that. That was originally for that was discovered to dilate eyes or something like that. And now we're putting it in the body so many places you can't even count. And so it may be that this drug ends up being that way too. So it sounds like it's going to open up a lot of doors for people in a lot of different ways. And I'm really excited to get this going. So if somebody wants to learn more about this, what's the website they should go to? I know there's a St. Renatus website, but there's also I think both
Kovanaze and St. Renatus will take you there, and then there is a St. Renatus helpline, I believe. I'm sure that's all on the website. And I am available for clinical, and I call everyone. Who calls that has an issue, pro or con. There's really only been one adverse event issue, and it's very small. It's about 2. And again, compared to injectables, it's crazy. But some people will have a stinging or burning in the nose afterwards. It's about 2% of the people, 3% of the people. Trying to determine why, because we didn't see much of that in the study, and we haven't seen much of it clinically. What it seems is if it's delivered too aggressively in dry mucosa and the stream or jet is sprayed right against a friable part of tissue, you'll get a little bit of a stinging afterwards. And it's been resolved the couple of times we've had it with any of the glucocorticoids, Flonase or any over-the-counter stuff, or even a saline neti pot. But again, I'm a clinician, so I don't like hiding anything other. It's easy to talk about the really good stuff. And I also like to, again, I've been lecturing on implants for 30 years. Implants work really well when you put them in the bone where they're supposed to go. And so, you follow directions and you do these things. And I like to hear the pros as well as the cons. I have many wonderful testimonials from doctors who are incorporating it. But I'm a realist. So if you have a problem or it doesn't work for whatever reason, pick up the phone and I will help you.
Well, I can think of about 100 adverse reactions I've had to injectables in my 8-year career, and it's almost weekly that you get one. It's like, okay, you're putting one in an artery, or someone's having a reaction to this, or I mean, someone's fainting, or, I mean, it's just, so the 2% stinging of the nose, I think I can deal with. It's, you got to look at, and hemorrhaging or bleeding or, bruising from injections. And, I mean, think about all the trauma you do, sticking people with needles. I mean, that's just a whole bunch of trauma before you even do the procedure. You're poking people in the face 10 times. That's just poking a lot of holes. Phil,
that's such a great comment, because it's funny. The new drug, the best example that I can think of, analogy is, Thanksgiving at your house. You have the crazy cousin who comes over every year and wrecks it. He's obnoxious, right? That's your old injectable. We all know that guy, right? He's there every year. New guy, your daughter brings over a fiance. If he puts his napkin in his lap wrong, you're mad at him, and that's how it is with a new drug. Can you imagine someone calling you and saying, after they had 14 injections to do all their, prep all their upper teeth, that their nose stung a little? You would go, well, that was a giant win. All that happened is your nose stung.
Yeah, exactly.
Right?
They tell me their face is swollen for about 3 days. Yeah. I say, well, that's because I stuck 14 needles in the front of your lip. I mean.
I know.
Yeah,
I know. It's remarkable.
You've got to think about the alternative, I think. So a little bit of sting in the nose is a breath of fresh air, I think.
Exactly right.
So, yeah, I think it's exciting.
There are a number of other things that this drug will do, and we're going, we're going off there, but there are doctors that, one thing you will notice, and we can talk about it, I guess, as an adverse event. Let's say that you ineffectively sprayed someone and the liquid ran out on their lip. If liquid runs out on your lip, that's an ineffective spray, because it really 0.2 mils belongs in the nose. It's just like mist. And so you shouldn't see any runoff. In the instances where that happens, and this were to run down to the lower lip and hit any of the mucosa or even the vermilion border, a side effect, an adverse event, will be profound anesthesia of the lip. So there are doctors who have decided that maybe that's something that would be interesting for Restylane or some of these other procedures. It appears to, adverse event type thing, have a profound topical effect that's nearly instant on any of the wet tissue. So there's going to be some medical applications for this sort of thing as well. Anywhere there's mucosa, this Tetracaine is a remarkable anesthetic. So you'll find that by accident in the clinic probably, but some people have tried to use that for good, as we do.
I'll probably actually find that on purpose. I'll do 2 up the nose and 2 on the buckle mucosa at times if I'm doing surgery.
I didn't say that, Phil.
Yeah, no, I know you didn't, but I'm going to say it. I'm going to do it. That'll be my second video. Is the first one will actually be just doing fillings and crowns. The second one I'll do 2 in the nose and 2 on the buccal mucosa, and I'll take some teeth out and put some implants in and say, oops.
Well, I hate to get into politics, but for those of us who are real doctors, I believe it's Gottlieb was put in as the head of the FDA. And just today or yesterday, and he's a proponent of find out what drugs can really hurt people and that have these serious adverse events, and keep those off the market. The other drugs, let's get them in the hands of our most educated clinicians and let them tell us what their benefits are. And so that's been missing for a while. Not a shot at the old administration, but the path to, no one would have Articaine or Septicaine. It would not be in our clinics under the most recent FDA rules of approval. This drug took 10 years and $100 million for 2 old drugs that have been around since the start of World War II. So this is hopefully going to be a pathway where those of us who are clinicians can do what we always do. Hi, Phil. This is what I know about the drug. This is what I've seen. This is how it works. And judicious use along these lines will help your patients. So that's what I like.
Well, that all sounds pretty good to me. So any closing notes we need here? I've got to get back to the clinic, and I know you're on break from a conference, I think, right now. So anything anybody needs to know that we haven't talked about other than just go to the website, and that is Kovanaze.com, Kovanaze.com. And is that you they're going to find on all those pictures?
That's me.
All right,
that's
good.
Me.
Good.
Yeah.
And then
yeah.
You've also got and then other than that, you just got to get it in your hands and try it. I know I'm going to get it hopefully real soon, get it going and give it a try. And I'll post some of my effects in some videos and pictures on my website and my Facebook page for this podcast, and then I'll put some links to Kovanaze on there too. And I'm going to see what we can get going here.
Phil, it's been a pleasure. Thank you so much. I'm available for any of your listeners with pros and cons of more questions. We'll get them answered. Again, there's a promotion going on that's a buy one, get one. Any of the dealers the dealers all have different pricing. Okay. So they're allowed to do that. So you may find a better price with a different dealer in your area. I'll leave that up to you guys. Run into any roadblocks, call me or the Kovanaze website information, and we'll get you answers. And I thank you all for your time.
All right. Well, hey, Mike, it's been a pleasure. I hope to see you at a conference coming up, and look forward to getting this product going. So you have a great day.
Thanks, Phil. Thanks so much.